Hello everyone. Few days back I have uploaded a video regarding thesis for a DM residency. There are few residents of MD medicine who are having doubts related to their thesis topic. Even though the first year residency have started few months back, still few students thesis topic not yet finalized. And they are having query with related to the which nephro topic is easier or which is easy to do. So to sort out their queries, I am uploading this video. First, in your institute, just be clear whether it is a retrospective study or prospective study which is allowed. Because few institutes allow for retrospective study also. Retrospective means you are taking the past data and presenting it as a research material. Prospective means you have to do a futuristic study, including now, follow up after 3 months, something like that. The rules vary from institute to institute. If it is prospective study or if it is retrospective study, you can select the topic accordingly. Usually the retrospective thesis topics are somewhat easier than the prospective one. Then second thing, what a MD resident should be aware of regarding the thesis. After the undergraduate level completion of MBBS, probably this is the first time you are encountering the research related area. So selecting the thesis topic basically include how practical it is, how easy it is. Don't take a very hi-fi topics which will be very difficult to complete at the end, because you will be in the mid of second year or third year once you are going to complete the thesis. So during that time there will be problem in the statistical analysis or the result which you got, or the marker that you are doing might, the biochemistry lab might not support it, or the co-guide might be somewhat strict. So these are all some practical difficulty. So try to take a topic which is easier to do. Mostly your guide usually helps the student. And in this video, I will go through the topics which you can select. Why these thesis topics are given? Just to add evidence to the literature, or how is your research work during, whether you are getting exposed to how to do the research work or not during your MD residency. And whenever you select a topic, always check whether there is a previous study related to that is there or not. And mostly whenever a MD resident is doing, that topic given to you might have been done before also. Probably 1 or 2 studies might have been done before. So the institute or the consultant wants to add evidence to it. That is why usually the topics are given to the student. Mostly 90% you will have definitely have a previous study. Or suppose if you're working on a new drug or new research topic, probably you are doing it to add research to the evidence to the literature. And how to get the previous research material related to that, whatever the topic. For example, if you are going to work on FGF23 and some new biomarker, take all the previous study related to FGF23 and see how they have did it. With that you can formulate your review of literature and further thesis proceedings. And when we take nephro topics for a medicine resident, the 4 core topics are diabetes, CKD, AKI, and electrolytes. Because under these categories, you can finish off the thesis without going to nephrology OPD. Suppose if your if your thesis topic involves the dialysis, probably you might have to go to nephrology OPD to catch the bulk of patient. Because the bulk of patient who are on dialysis won't come to medicine OPD. Mostly they will be reaching nephro OPD directly. So that is why if you take the topic which are related to diabetes, CKD, not on dialysis, acute kidney injury and electrolytes, it will be practically during your residency, it will be very easy to do. And mostly the residents whom I have met for the last few months, they were asking, sir, tell me some topic which is very easy to do, so that I won't be running around during my first year or second year for exclusively for the thesis purpose, because already medicine residents are overburdened in most of the institutes. So that is why keep the thesis topic related to this area so that it will be easy to complete. And this is the broad topic: diabetes, AKI, CKD, or electrolytes, with which you are going to do, you can select. And again, similar to DM residency, as I have told how we can classify. For a MD resident, probably it was somewhat uh, simplistic. They won't expect a hi-fi thesis. Hi-fi comparison might not be required. The thesis can be looking at the outcome of the disease. For example, outcome of UTI in your institute, or the thesis which are related to the markers. For example, albumin creatinine ratio, yeah, NGAL, urinary NGAL, with respect to AKI, with respect to CKD, this kind of marker related thesis you can plan. And if related to outcome, not only UTI, you can plan for any disease, outcome of AKI in a tertiary care center in South India, North India, or Central India. The number of patients you have to take depends on your guide and the previous studies. And at least for the MD level, even a 50 patients might be enough to complete the outcome studies. Third is another simplistic form of studies, the clinico-etiological analysis profile of any disease. For example, sepsis-induced AKI, clinical etiological profile of diabetic nephropathy presenting with UTI. These kind of particular disease you can select, and that patient's clinical profile. Clinical profile means you are checking why the patient presented, what is the etiology. Basically, broadly, you are analyzing and presenting it in a research format, that what is the age group, what is the presenting complaint, like that you are going to classify. For example, AKI you can take, diabetic nephropathy you can take, CKD stage wise you can take stage 3, stage 4, stage 5, whatever you want. You can take this kind of clinico etiological with some investigation, whichever investigation. For example, ultrasound, for example 2D echo, carotid intima media thickness, whatever you want to put, you can put. Probably few of your seniors might have did it, and for the particular institute, the thesis topic that you are selecting, for the past 5 years, that institute, any student should not have did it before. So that is why keep a check or get the list from your medicine department PA. They will be having the list of past year thesis. Make sure it is not done before. Otherwise, you will be selecting the topic. Then after some time, you will come to know this was already done by your senior. So you can't do it. So that is why make sure you have checked it before. Because few years back, this is a famous type of thesis study where clinical etiological profile of AKI, CKD, these kind of analysis, which will be easy for the student also as well as guide also. And publication is also somewhat easier, at least in the Indian journals, you can easily publish. Fourth one is the comparison trial. For example, you are comparing a patient of diabetic nephropathy and a patient who are not a case of diabetic nephropathy with the diabetes, and checking their outcome in terms of a particular thing. For example, incidence of UTI, for example, incidence of progression of urinary microalbumin. These kind of study you can plan. Few institute won't allow drug trial. Suppose if drug trial is allowed, MD medicine resident can't start the drug with respect to his research activity, but he can take the patient who is already on drugs. For example, you can take a patient, 30 patients of diabetic nephropathy who are on dapagliflozin, 30 patients of diabetic nephropathy who are not on dapagliflozin. Just compare them with respect to the EGFR progression, urinary albumin creatinine ratio progression, or creatinine, uric acid level, any biochemical parameter you can take and you can just compare with the patient who are on a particular drug, not on a particular drug. These are very easy to formulate, and that is how you will select the thesis topic. Just select the broad topic, try to find which is very common in your institute. Ask your third year or final year or your senior resident consultant, probably they will be knowing it better, what is a particular set of cases which is more in your institute. Try to, for example, if it is UTI, that thesis topic can be related to outcome. You can check some marker, for example HbA1c or serum magnesium level with in UTI, and just you want to assess the clinical etiological profile of UTI in your institute, or you can compare it, or any drugs if you want, you can plan like that, so that You can plan a simplistic thesis topic, and your usual duration of follow-up is 3 to 6 months. Don't take a big study like DAPA-CK. There are various fancy trials which was done at the international level. There are few amateur students who want to just mimic that big trial into this thesis. Very difficult because you are individually going to do the thesis. So you have to plan it in a simplistic way. Okay, I have told the broadly how to select the thesis topic. Still, many students want to know particular topics. Tell me particular topic which I can do in my institute. To them, I have kept few thesis topic which related to the various broad headings. First, for example, if you take diabetes, you can plan assessment of microalbuminuria in pre-diabetes patient, not in diabetic patient. Very easy to get. Microalbuminuria level is also very easy to get. So you can catch approximately 100 patient, assess the level in pre-diabetes patient. Clinical characteristic, USG and echo finding in early diabetic nephropathy patient. You classify the patient into early and late and try to find what is the clinical characteristic, why they are presenting to hospital. This kind of study can easily get published also. Another one is clinical etiological profile of UTI in diabetes versus non-diabetes patients. Just you are taking, for example, 30 patients of diabetes and 30 patients of non-diabetes, and you are assessing what is the most common, whether it is cystitis, pyelonephritis, or simple urethritis, whatever it is. You are just assessing the clinical etiological profile. What led to this kind of UTI? What is the risk factor? Whether they are immunocompromised or not? These kind of analysis you can do. Diabetic nephropathy, impact of drugs like dapagliflozin, febuxostat, AC inhibitors, telmisartan, losartan, ramipril. There are many drugs. Easily you can catch 30 to 40 patients who are on ramipril, who are not on ramipril. Just to compare their progression over a period of 3 months, 3 to 6 months. Even in my institute, there are few students who are doing this topic. Very easy to do the follow. With 30K in a OPD, if you are in your OPD, if the count is more than 200, 300 patients per day, even a per day, you might get 5 to 10 patients. Easy to do. Diabetic nephropathy, hospital admission analysis. Why a patient of diabetic nephropathy getting admitted to the hospital, whether it is because of nephro-related problem or just because of some other problem, you can do a etiological analysis. Vitamin D level, IPTH level in early diabetes and non-diabetic CKD. CKD, whenever this term comes, you classify into the stages, various stage. You can plan the study very easily. CKD stage 4, stage 5. There are evidence which are less. You can keep on adding evidence to the literature, can be easily published also. HbA1c correlation in diabetic nephropathy progression. This was already done. A very famous 2015 to 19. During that time, this was done by almost most of the first years during their residency, because this is the topic the senior usually recommend. At least one resident for a particular institute, definitely he'll be doing on it. So there are a lot of publication already on this. Urinary ACR level between diabetic nephropathy cases. Just a minute. Sorry for the disturbance. Another one is profile of sepsis in diabetic nephropathy admission. What is it? Just you are checking in diabetic nephropathy patient, what is the profile of sepsis, whether it is bloodstream infection, whether it is pneumonia, whether it is UTI. Along with that, you can plan the outcome also. Anemia profile you can catch between diabetic nephropathy CKD and non-diabetic nephropathy CKDs. These are all the simple and common topics in diabetes patients, or thesis topic which are related to diabetes. Next, a few topics which are related to AKI. Outcome of AKI in ICU. Whenever you take AKI, a patient who is getting dialysis usually get transferred to nephro. So that is why try to keep your AKI restricted to non-dialysis patient, which will be easy. Suppose if many AKI patient gets dialysis once or twice, after that patient probably gets improved and get discharged. So those kind of comparison you can easily make, and those are very good topic also. Again, clinical etiological and USG profile between HD and non-HD AKI. Sepsis in AKI. What is the profile? Why the patients are developing AKI? In what kind of sepsis? These kind of research topic. Some marker level of high sensitivity CRP in AKI. Urinary NGAL or cystatin. For this, you need a support of the institute because they have to give fund for cystatin and urinary NGAL in AKIs, or some serum magnesium level in AKI. Simple correlation type of things you can plan. And another important topic is impact of IVC diameter on admission in AKI. Even though this heading looks somewhat difficult for a first year resident, but assessing the IVC diameter you can easily do if your institute is having a ultrasound in the ICU. Just like that, you can go keep the probe and find the IVC diameter, and correlation you can easily find it out in AKI. And this might be the simplest of topic, which will be easy to complete. No much follow-up required, just you can see the correlation of IVC and the outcome. Pre-renal AKI, you can catch only the cases of pre-renal AKI because most of the time pre-renal AKI used to be under medicine department. So you can do a ETU pathological analysis, hematological parameters in patient of non-HD AKI. You are just assessing hematological parameters, whichever you want, you can select that. Ratios, there are so many ratios, platelet neutrophil ratio or the CBC count, hemoglobin, whatever it is, you can plan a study on that. Clinical profile and role of urinary sodium and potassium in AKI outcome. What is it? It is nothing but you are checking you are checking the urinary sodium and potassium in AKI patient and comparing it with the outcome, how it correlates. So the number of research article on this topic is very less. You can plan on this. Hyponatremia or any electrolyte and that correlation with the AKI outcome, whether the patient improved, whether the patient deteriorated, whether the patient landed in dialysis different state or expired. Within the electrolytes you can plan, and few topics which are related to CKD. Mostly in medicine department, CKD both in IPD or in the OPD, probably over a period of last 6 months you might have seen this set of profile of patient is very easy to get. So if your thesis subjective, your consultant is saying I want to hit a higher number, then you can catch this broad topic. Profile of biochemical abnormalities in CKD MBD, easy to do. What are you are going to check? Calcium, phosphorus alone or in combination? IPTH, vitamin D. You can check per individual stages. Whenever the CKD broad topic comes, you can do for CKD stage 3, 4, 5, or broadly patients who are not on dialysis and who are on dialysis. The point with respect to who are on dialysis is mostly the follow-up will be the nephrology OPD. So you might not get the patient, or you might have to visit nephrology OPD. So try to avoid the dialysis patient. Try to take only the non-dialysis patient, or just for few comparison you can take the dialysis one. Clinical profile of patient getting started on HD. So you are referring to Nephro to start the HD, you are getting the clinical profile. FGF23 and malnutrition in CKD particular stage, whatever it is, 3, 4, 5, you can plan. FGF is fibroblast growth factor 23. Your institute have to fund for it. Biochemistry people have to recruit the kit to check for it. Malnutrition, you can use any score. Clinically very easy to do. HbA1c and TFT levels in non-diabetic CKD. Already done before. Thyroid level in non-diabetic CKD, or you can take diabetic CKD also. Why we are taking non-diabetic CKD? Because HbA1c might have been done in a diabetic patient. So already the evidence or publication wise it might be difficult to publish. So you can select a non-diabetic CKD. Erythropoietin and quality of life. The patient who are started an injection erythropoietin in CKD stage 3, 4, 5, you can affect the quality of life. How to check the quality of life? You can use some scale clinically by asking the history. You can use some scale to check on the quality of life, which is very easy. Serum magnesium level and IPTH in patient AKA and CKD. Profile of vaccination. This is a very good topic because Even at the nephrology DM residency level, profile of vaccination, knowledge assessment practice, how much the patients are sensitized regarding vaccination in CKD patient. Very good topic, can be published at international level also. Iron profile and lipid profile correlation in CKD patient, because CKD patients are more prone for iron deficiency, and you can correlate it with lipid. This one topic we have did around 5 years back, so you can modify some of the parameters and you can try to make a thesis on it. Anemia profile, if you are taking 100 patients of CKD stage 4, what is the anemia profile is like? Iron, vitamin B12, or what is the parameters are like? What is the peripheral smear? At least in the particular institute, you can publish a thesis on this. Outcome of CKD patient not on dialysis. You can take a CKD patient around 15 number who are stage 5. Age 5 you can classify. Suppose if they are more than 60 years, you can try to find outcome of those patients who are not on dialysis and how they are performing after 3 months. These are some simplistic studies. So the last, it is all, the video is already getting lengthy. I hope you might have got your topic from the previous discussion. I hope this might be helpful with respect to electrolytes. If I keep on discussing all the individual topic, it will be way too lengthy, so you might get bored. So I'm stopping at this point of time. Some of the topics related to electrolytes. This study we are planning in our institute also, correlation of 24-hour urinary potassium level and hypokalemia recovery, dapagliflozin and empagliflozin, any two drugs you compare it for 3 months. Hyponatremia and AK recovery, take any electrolytes and compare it with the recovery. Spot sodium, potassium, not only in CKD, you check in CLD, you check in CCF, you check in CVA, any infection, take spot sodium. Spot sodium is very easy. Probably if the institute is having its own lab to check it, probably. Yeah, another easiest form of thesis, you can easily publish it also. So I hope from this discussion you got which topic you can plan with related to nephrology. Always check practicality, how easy it is, because it should not be a time consuming one. Try to keep minimal co-guide, because co-guide might come with their own set of rules. It might add difficulty to your thesis. Less co-guide, the number of patients actually will be selected by the previous study. I hope those residents who didn't get the thesis topic so far, probably you can select from any one of this. And suppose if you didn't get from the particular topic I have discussed, you can apply the broad categories like diabetes outcome. Try to match one and find one. Okay, bye bye. I hope this was helpful to you.